Greetings, everyone. Welcome to the 248th session of the online Optom Learning Series OOLS. And for today's session, we have with us Mr. Vigneshwar Goppalakrishnan. Vigneshwar is an assistant professor at the School of Allied Health Sciences, Vinayaka's Mission Research Foundation, deemed to be university. And he has a vast experience in fitting contact lenses. He is a former contact lens consultant at the LV Prasad Eye Institute. He finished his undergraduate degree in optometry from Vasan Institute of Ophthalmology and Research in Chennai, and he also holds a postgraduate degree in optometry from the Elite School of Optometry in Chennai. He's also been awarded the prestigious Fellow of the American Academy of Optometry AAO, and currently in the process of pursuing his fellowship by the BCLA, British Council of Optometry. He's a member of the BCLA, and he enjoys teaching optics as well as contact lenses to undergraduate and postgraduate students. And on the clinical upfront, he's also seeing patients and fitting patients with irregular corneas with variety of contact lenses available to his disposal. With all that experience, Vignesh is going to talk us about one of the, I think, quite commonest complication, I would say, seen with scleral lens, where when it comes to understanding the midday fogging and how can we help patients who suffer this problem, which is midday fogging. And he's going to take us through what is the available evidence in the current literature about helping patients with midday fogging. So welcome, Vignesh, onto our platform. Thank you for spending this evening with us today in explaining us about midday fogging. And let me just leave the screen time to you now.
Hey, hello everyone. Thanks. First of all, I would like to thank Mr. Fakhruddin and OLS for this wonderful opportunity. And I welcome you all to the session on this weekend. Without further delay, we'll get into the topic. And this topic I've designed to take you through the evidences and this to generate few research questions related to this topic and clinically how we are going to approach midday fog. So the topic is midday fogging in scleral lenses and evidence-based review. So scleral lens, first of all, we'll see few terminologies to understand the presentation better. Scleral lens is a large diameter rigid gas permeable contact lens which rests on the conjunctiva overlying the sclera, vaulting the entire cornea and the limbus. This vaulting generates a space between the posterior surface of the lens and the anterior surface of the cornea called fluid reservoir, which is filled with preservative-free fluid. Over the period of scleral lens wear, particles accumulate in the fluid reservoir, leading to increased turbidity. The right side image shows the clinical picture and ASOCT image of a clear fluid reservoir and a fluid reservoir with increased turbidity. So, fluid reservoir can be observed using a slit lamp biomicroscope by creating an optic section and focusing on the vault if the debris is present, and it can be appreciated to this examination. So around 20 to 45% of scleral lens wearers reports a foggy or cloudy vision, usually after 3 to 4 hours of scleral lens wear. This subjective phenomenon is termed as midday fogging. The image on the right shows the particulate matter which makes the patient to complain of midday fogging, which is present in the space. And I want a little help here from Fakhruddin. Fakhruddin, can you please launch the first poll? Thank you.
Yeah, so the poll is up. We just want to understand your thoughts on what are the reasons for midday fogging. Is it because of the fluid reservoir thickness? Is it because of the ocular surface inflammation? Is it because of the fitting itself, or it could be due to other or multifactorial in nature? So if you could participate in the poll, that would be great. If you don't see the poll, whoever is on the Zoom, you may need to press the more option, the three dots, and the pole should be visible there. So I think majority, almost 60% of the attendees thinks is multifactorial, followed by the fitting related scleral lens fitting related issues, and then the thickness of the fluid reservoir, and finally the ocular surface inflammation. So that's what our attendees think. Yeah.
So that's great, and yeah. So the answer is actually the cause, exact cause of midday fogging remains unknown still. And however, the composition of the fluid reservoir includes immune cells and pro-inflammatory molecules and lipid substances, which contribute to the turbidity in the fluid reservoir. Here, Dr. Walker has did a significant contribution towards this midday fogging, where she reported the lipid presence in the scleral lens fluid reservoir, and in few other papers where we found the inflammatory molecules and the pro-inflammatory, immune cells, including leukocytes, everything. So here, I would like to ask, what could be the vision problems that usually you see along with midday fogging?
So a couple of them have mentioned it could be due to the deposits on the lenses. It
Right.
could be due to debris collection. Yeah, a couple of them are saying debris collection under the tear reservoir. And it could also, people think about due to the wettability of the lens itself, that could lead to drop in vision with scleral lenses. And high fluid reservoir thickness related to hypoxia. So these are the
Right.
commonest responses, Vignesh, which I
Yeah,
have.
yeah. So that's so nice to see those exact terms. Actually, when it comes to wettability, that's one of the very important factor that affects the vision during scleral lens fitting. In a trial, we used to see based on the condition, based on the ocular condition, if they are ocular surface disorder patients. So they used to say that the vision is so foggy, and if we see in the slit lamp, we can able to appreciate the wettability issue, and one the other factors, the hypoxic reaction that they have mentioned. So yes, yeah. So the differential diagnosis for the midday fogging is a clinician must ensure that the visual compromise following the scleral lens wear is not caused by epithelial or stromal edema, but rather by debris accumulation in the fluid reservoir. So I just want to re-emphasize that the visual acuity drop or the vision drop in the scleral lens wearers because of the debris collection in the fluid reservoir, then we call it as midday fogging. Other reasons for vision drop, we don't call as midday fogging. And when fitting compromised corneas, it is actually very important to avoid hypoxic stress associated with scleral lens wear. And additionally, front surface debris. So that also plays a very major role when we are doing a scleral lens trial. So front surface debris can also affect visual acuity after scleral lens wear. So it is essential to differentiate whether the vision compromise is due to the fluid reservoir turbidity or the front surface debris on the scleral lenses. So if the patient encounters that their vision is again and again getting fogged because of the debris, and if they say, and if we see that the front surface debris are playing a role, then usually we ask the patient to use the cotton buds, or we instruct them to instill a few drops of normal saline on top of the scleral lens to make the debris to wash away. So we are entering into the fluid reservoir turbidity. That's the main contributor for midday fogging. So the debris contributing to fluid reservoir turbidity originates from multiple sources, Physiologically, epithelial cells are slowed off as a part of a natural process of blinking and regeneration, even without lens wear. So epithelial cells however, during scleral lens wear, epithelial cells are often found in the fluid reservoir, potentially as a response to the filling solution itself, because non-preserved saline is typically recommended for a fluid reservoir, but even standard saline has been shown to increase corneal epithelial slowing. And in addition to epithelial cells, the fluid reservoir contains higher levels of inflammatory markers compared to the basal tears of the healthy eyes. Actually, this statement, this evidence in the literature suggests that the scleral lens wear itself may induce an inflammatory response, rather than, because in this study they have seen the inflammatory markers that have been found in the fluid reservoir, and they reported that mmp1 and 9 are found more in the fluid reservoir compared to the basal tears. That means the scleral lens itself, it's creating an inflammatory response from the ocular surface. So in clinics, we use a slit lamp biomicroscope to observe a fluid reservoir turbidity. And two types of particles usually we observe here in the image as mentioned. One type consists of yellow or brown particles, while the other consists of large white or wispy clumps. And studies assumed that the yellow or brown particles could be because of the lipid deposits that are generating from the ocular surface, or the white lumps or wispy clumps or mucins that has been producing from the ocular surface. So the evidences are that the FR consists of leukocytes, and the fluid reservoir is filled predominantly with neutrophils. But in this study, they did not find any statistical difference between the Fogus and the non-Fogus group. And this also found that the lipids were also present in the fluid reservoir, that too the non-polar lipids found higher in the group of Fogus compared to the non-Fogus. And here, the wax ester and cholesterol ester are usually secreted by the meibomian glands, and triacylglycerols are in the natural tears itself. So these lipids also a contributor for fluid reservoir turbidity. And a recent study in 2024 by Walker et al., they highlighted that pro-inflammatory markers are found in fluid reservoir and might have association with severity of midday fogging. So next, let's look at the evidence on how visual fluid reservoir turbidity impacts visual function. In this table, the study by Turan et al. Estimated the optical density of the fluid reservoir and the high and low contrast visual acuity in keratoconus population. They used a pentacam as an imaging instrument and captured in 1 hour interval over 4 hours of scleral lens wear. And the optical density of the fluid reservoir significantly increased after 1 hour and decreased in the low contrast visual acuity. And they noted a decrease in low contrast visual acuity after 2 hours of scleral lens wear. And in the second study by Shornack et al., optical density changes noted in the first 20 minutes of scleral lens insertion as they've studied in the healthy eyes. So this is so confusing when it comes to clinics. So which is the factor that is reliable, that is really contributing to midday fogging? And in the third one, Kersero et al. Used ASOCT to image the fluid reservoir and reported that the visual acuity and the contrast sensitivity both reduced after 8 hours of scleral lens wear, and an association was found between the fluid reservoir turbidity and the visual acuity. So here, they did not find any significant contributor for this midday fogging, but still they have found that there is a reduction in the vision. And as we spoke about the factors, so midday fogging has appeared to be multifactorial, where we have evidence that the lens fitting parameters were associated with midday fogging. And it was found that the average thickness of a fluid reservoir was higher in the groups of foggers compared with the non-foggers, and was reported that the foggers had tight fitting lenses than the non-foggers, and the midday fogging was found to be lesser in the scleral lenses fitted closer to the scleral contact. Actually, when we are attempting to fit a lens, we always see these factors are controlled, and still we tend to see midday fogging that is occurring with the patients. And here we have few guidelines to fit how the scleral lens fitting should be optimal, and still we encounter midday fogging in the clinics. So, what is when it comes to the association of fluid reservoir thickness and midday fogging? Fluid reservoir thickness was found to be higher in the foggers group compared to the non-foggers, and a study suggested that increasing the FRT by 50 microns, the odds of resulting in MDF increases by 2.24 times. And in contrast, a study reported no difference in the fluid reservoir thickness between the foggers and the non-foggers group. Also, the study did not consider the haptic alignment. So this is again whether there is a relation between fluid reservoir thickness and the MDF is present or not. So still it's confusing. And however, a study report that there was no correlation between the fluid reservoir thickness and the amount of turbidity. When we are moving into haptic alignment and its association with midday fogging, again, literature suggests that the friction of scleral lens haptics with the conjunctiva itself creates an inflammation which may result in excessive mucin production. Means that the again, as we discussed earlier, scleral lens itself, it's an inflammatory, it's a trigger point for the inflammatory response in the ocular surface. So it was found that the patient who had the interrupted scleral lens wear due to midday fogging had a tight fitting lenses. So again, when it comes to haptic alignment, it suggests that when you fit the lenses so tight makes that the suction and increased suction, and there is no tear exchange, then it is assumed that the MDF is a factor that is because of the haptic alignment. Again, fenestrated when it comes to fenestrated scleral lenses, the literature suggested that fenestrated scleral lenses reduced midday fogging because it's because of its less suction, improved tear exchange, and less conjunctival pressure that is happening due to the fenestration that is made in the scleral lenses. And this gives us a question: does suction has any association with midday fogging? Still, we don't have answers for that. And this is one of the research questions that has been generated from this analysis. And then when it comes to tear exchange as a factor with as a contributing factor for midday fogging, so it's always it's a kind of a conflicting results when we go through the literature, because few studies suggest that MDF can be reduced or eliminated when the lens is fitted so that the haptics is more closer to the scleral contour, and this is assumed to be that the tear exchange would be lesser so that the debris does not enter the fluid reservoir from the ocular surface. Meanwhile, if there is any edge left, and again, if there is any edge left, and if the ocular condition itself is an inflammatory condition, like people suffers from ocular surface disorders, then again the production of mucin and the production of the debris is going to be higher, which makes the debris to enter the fluid reservoir through that edge left. And I have encountered in this in clinics too, and I have managed this by steepening the haptics, and I have seen a significant result when it comes to addressing the midday fog. And haptic alignment plays a very crucial role with respect to MDF. And usually the sclera is not the symmetrical because more toric towards the rectus muscle. So to achieve the better haptics, we can try the toric or quadrant specific haptics. And in contrast, Actually, the same rate of midday fogging were noted even with the customized and impression-based scleral lens fitting. Again, all these factors are all this literature suggests that it's a little confusing. But interestingly, a study reported the tear exchange rate was same in Fogus and in the non-Fogus group. So, so actually, whether we can come to a conclusion that because of the tear exchange, it is leading to midday fogging, then it's not. So the last factor associated with midday fogging is the solution that are used in the fluid reservoir. And a few anecdotal reports suggest that using preservative-free artificial tears reduces the midday fogging. And it is believed that the viscosity of the solution is inhibiting the debris movement inside the FR from the ocular surface. A study reported the visual effect of midday fogging were reduced when the saline containing ions matching the natural tear composition. But a test solution usage in the fluid reservoir did not show significant difference in this particular study, but improvement in subjective response were noted. Again, this approach has not given any conclusion how to address the midday fogging. So all on the whole, with respect to research and clinics, the exact cause of midday fogging is still not known, and uh, this makes the clinician to find difficult to explain to the patient about midday fogging after spending so much of amount in scleral lens procuring. So, but the research suggested possible factors to address the midday fogging, and in clinics, it requires an individual case management approach, as we said. Right, researchers still exploring to understand the effect better, and it's difficult for the clinician as there is no perfect guideline. Still approaching how to approach midday fogging, and it's still in a trial and error basis, and it requires more exploratory and interventional studies with the different artificial tears to back up the statement, which is already we discussed that whether the artificial tears in the fluid reservoir is going to reduce the midday fogging or not. And the clinicians are following possible managements using preservative-free artificial tears in the clinics. So the clinical, how to approach the midday fogging in clinics. If you find the ocular inflammation, check for the requirement of pharmacological interventions, whether it is required to reduce the inflammation first. And if you find a higher fluid reservoir thickness, then try to reduce it and make sure the haptics are aligned properly. And if the edge lift is noted, then try to steepen the haptics, or if you find the steeper haptics or suction, then flatten it. So these are the trial and error methods that how you can approach the midday fogging in clinics. But always the cost-effective approach is ask your patients to remove the lens, clean it, and refill the bowl and reapply it. So this is how we address midday fogging in clinics, and still research is going on towards the identifying and exploring about what is the cause and how we can exactly manage the midday fogging. Yeah. Thank you all. Thank you, Fakhruddin, for this opportunity once again. And I would like to acknowledge these incredible individuals and the organizations who have been the driving force behind my career.
Thank you so much, Vignesh, for that comprehensive, evidence-based talk. Because we do know that this is a problem we see in a lot of our patients, but it's really good to understand about what are the different evidences and how can we apply this. I think the second last slide, what you put, how to apply this into our clinics is really very important. I mean, research is been going on, but it comes to real life when it is when you are in the clinic, examining patients, and how can we use this amount of information to help our patients, right?
Yeah.
Wonderful, great. So, and I think somebody also tried to answer as well. Does persistent turbidity result in long-term changes to corneal health, and how would you look into managing this as well? If you could like to add on something.
Yes. So the persistent when it comes to turbidity, and again, literature suggests that this turbidity is adding the inflammatory response, because a recent study published in 2024 by Walker et al. About the pro-inflammatory markers. It's an in vitro study where they looked for the inflammatory markers in the fluid reservoir, in the fluid reservoir, and they said that yes, the contents in the fluid reservoir, it's giving a way to increase the flow severity of the MDF. And when it comes to specific to this question, still I don't have any answer for this as I mean, from a scientific point of view. But still, yes, because it's going to alter the visual outcome of the patient, and so that's the only point that I can add here, because whether to a corneal health, I don't have any answers for it from I mean, to back up with scientific evidence to stay
Yeah.
to answer this question.
Right. Yeah. I think it's also important for us as clinicians, if you put on clinician hat on, if you suspect that the patients, during your follow-up have persistent turbidity in terms of observing clinically, perhaps you need to do more assessment of the cornea rather than just the slit lamp. Perhaps would you do something else to just make sure the cornea health is not affected so much?
Yeah.
Right.
So adding to that, never ever the scleral lens fitting is going to end without a slit lamp examination. And
Yeah.
after removal examination, after removing the scleral lens, again we have to have a look at the cornea, how it is, and stain the cornea and see how the ocular surface is. Without staining post removal, definitely your scleral lens fitting is not going to end, and the judgment after that is going to really play a role in fitting these clear lenses, in successful fitting clear lens. Yeah.
Yeah. Yeah. That's really important
And
point.
the corneal health, the ocular health comes first when we are fitting scleral lenses. So corneal and the limbal health is very much required or very important when we are going for scleral lens fitting. So we have to look into that
Look
also.
into it. Yeah. Perfect. Yeah. And I think you did mention about filling the bowl with saline and other solutions. So, do you have any experience on mixing perhaps the artificial tears or lubricating eye drops with saline? Does it help in reducing the midday fogging, or anything in terms of changing the filler? So, have you looked into it,
Yes,
or any
yes,
ideas?
actually, yeah. So we have experienced it, and we have seen the cases where the haptic alignment is good, and the central FRT is, I mean, the overall FRT is fine. It's adequate within the range. It's not excessive. And all other factors, when we arrested, still we encountered the midday fogging effect, and we saw the fluid reservoir turbidity in the space. And then we thought that, okay, we can change the filling solution. So we march forward towards the changing the solution and make it more viscous. And again, it's a kind of a mixed result. For a particular patient, we saw that it's drastically reduced. The turbidity drastically reduced, and there were no complaints at all. The patient did not report any complaints. They felt it's very good, though it is not clinically helping. I mean, in few patients, they did not report that the vision is improving, but the comfort, for particularly for ocular surface disorder cases, they felt so good when we used artificial tears. I mean, preservative-free artificial tears as a filling solution. And coming to debris collection, we saw for few patients that it drastically reduced. For few patients, it did not. Honestly speaking, it did not. So again, so that's the reason I couldn't able to say that definitely filling artificial tears is going to help the midday fogging.
Wonderful. Great. Yeah. So also because you said it's multifactorial perhaps, and the reason also we are still finding. So it perhaps looks like it is case based rather than you
Yes, yes.
generalize midday fogging at this point in time, I think, right?
Yes, yes. Actually, that's where keep on researchers are highlighting that this is a kind of a multi factorial in nature, and the approach should be like the what's the problem in that particular case, and
Yeah,
you start to address to that, which and all found as an evidence that might cause midday fogging. So it's a kind of an individual case scenario how you manage it. It's not like
right.
you can sit and you can directly say this would be the
This would be the
cause.
final
Yeah,
outcome and help the patient. So
yeah,
it doesn't
yes,
work that way,
yes.
unfortunately.
Yeah.
Yeah.
Still, researchers are working on towards it. Still, they are doing exploratory studies to understand the midday fogging better. And still, we are getting, if you go through the literature, still we are getting papers related to this, and it's adding the evidences to the previous literatures.
Yes. Yeah. Wonderful. Great. A couple of more questions here. One is, have you come across any relationship between, the lens material properties, the decay value, the wettability of the lens, and its relation to occurrence of midday fogging? Is it that the material has some important role to play as well in midday fogging?
Yeah, actually, thanks, Prabhu, for this wonderful question. Actually, when we were doing clinics, and we do found these relationship when it comes to midday fogging. When we first, I'll just go by one factor: the DK value and wettability with respect to midday fogging. Yes, there are evidences that it is assumed that the hypoxic reaction also could trigger midday fogging. And when it comes to wettability, I don't see any evidences that wettability is one of the like relating factor with midday fogging. But obviously decay value, because when it comes to decay value, it obviously affect the oxygen availability to the cornea. And if the cornea goes in hypoxic stress, we have evidence for that this could also trigger midday fogging. And other than that, we did not see any connection between
Sure.
these factors and midday fogging.
Wonderful. Great. And let me just make sure that. So the other connecting question was, I think you were mentioning about modifying the fit perspective as well to reduce midday fogging. So somebody wants to know about toric haptic selection. Would that be an indication, and how would you go about using the toric haptics in these situations?
So when you go for a smaller dia, then the normal spherical scleral haptics would help better, because the toricity of the sclera is not that much when it comes to near the limbus. But when it goes towards the rectus muscle insertion, the toricity is going to be so much. Then, if you go for a very larger dia, or to cover most of the portion in ocular surface disorder cases, then obviously you will require a toric haptic. And it's very it's a basic requirement when you fit a scleral lens to make an haptic alignment better to the scleral lens scleral surface, because this friction or the slight movement in the scleral lens, that itself creates the physical insult to the conjunctiva, and that triggers the inflammatory response. So we have to make sure that the haptic is well aligned. And when it comes to toric haptics, when you go for a larger dia, you might require toric haptics very frequently, right? Because I can't say that you can't fit spherical haptics. You can fit a spherical haptics, but it's purely dependent on the scleral toricity. And when you go for a larger diameter, yes, obviously you might require toric haptics.
Yeah. And just on the discussion about diameter, I think somebody was kind of suggesting as well as wanting to know, would helping the size, the diameter of scleral lens itself help in midday fogging? And if you have a patient who has probably experience of midday fogging before, would you choose a smaller diameter, or would you think about changing the diameter first to solve this problem?
Yeah. So it's a very good question when it comes to clinics, how you handle this midday fogging cases. Particularly, if you ask me, it's going to be a first choice of option to change the diameter, then it's no. I'll not go to the approach directly. I'll change the diameter from larger to smaller. But still, the smaller diameter lenses works better because I have seen in my experience. I'm saying that the smaller diameter, like the incidence or the midday fogging occurrence is lesser compared to the larger diameter. That's what we observed, and we have a scientific evidence also for this that Dr. Walker has worked on this, and she has given a like in a very small sample, she has tested and she said that the smaller diameter lenses are showing lesser midday fogging compared to the larger diameter lenses because the site of lens protection are near to the perilimbal region. I mean, near to the limbus. So when you go for a smaller dia, then the debris that are accumulated in the fluid reservoir is lesser. So we have an evidence, but still we can't take that as a solid evidence because it's in very small group, and it's not a very extensive study. So we don't have evidence to back up the statement, but still I have actually, I mean, we have addressed midday fogging when it comes to diameter. We changed to the smaller diameter, and we've seen few patients are improved and in the visual outcome and with the respect to midday fogging.
Okay, yeah. So something to be considered, I believe, in patients who are able to fit smaller diameter lenses. Okay, and would smart channels, when you modify the lens fitting, especially with smart channels, do you think that could be the cause also for the midday fogging because you are now having uh, free flow of tear exchange and things like that? So, is that the reason?
Yeah. So again, I can't say this is the exact reason for it because because I don't have evidence to say that because few papers says that tear exchanges at least minimal amount of tear exchange is good so that it reduces the midday fogging because when we see the fenestration paper which I quoted in the last third slide or something where they said that because of the fenestration, the tear exchange is more, that is reducing the midday fogging, that is reducing the debris to come out from the fluid reservoir. And there is an exchange that is happening, and that is reducing the debris which are settling inside the fluid reservoir. And again, we have a few papers which are suggesting that there is no evidence to back up that the debris that are going outside from the scleral lens from the ocular surface inside the fluid reservoir or the debris that are coming from this fluid reservoir to the ocular surface, I mean outside of the scleral lens vault. We don't have the evidence to say that this is what the exact cause. But adding few in my clinical experience, we have managed few MDF cases by incorporating channels, but not particularly to improve the tear exchange to overcome the local hindrance in the conjunctiva to make the scleral to fit better.
Yeah, that's really informative, I think, because when we do a lot of modifications as well, you need to be a little bit careful as well because sometimes it may influence on other factors.
So what the clinical mantra that I follow is if patient is not complaining about anything. And if you assure that, if you see that there is no physical insult or the endanger, I mean, you don't see any adverse effects to the ocular health, then you give the lenses what you have fitted.
Yeah.
So because clinically you can't expect a textbook fitting in all type of conditions, and if patient is happy and in a clinical examination you see the ocular health is good and that lens is not going to cause any problem to the ocular surface, then please give away the lenses. Please
Yeah.
dispense the lenses. Yeah.
Wonderful, great. And I think a little bit about condition-based midday fogging occurrence. So this particular question talks about keratoconus when the patient was fitted with scleral lenses and fitting was optimum, but still had midday fogging. So my question is, do you think it is condition dependent? Do we see
Yes.
midday
Yes.
fogging
Obviously.
more on
Yeah.
certain conditions and
Yes. Yes.
yeah?
Yeah. So when we observed in clinics, the when you're fitting for a keratoconus, if a patient who has if we divide that keratoconus with any allergic reaction or with VKC, the incident, I mean, the prevalence of MDF is so higher in the people who are having an allergic reaction already, that is going on in the eye, and a patient which I'm fitting with a for a normal keratoconus condition. So I can see, I have observed that the people who have active allergic reactions, I mean, inflammations, they tend to complain that midday fogging is huge and it's happening within 20 minutes or 30 minutes of scleral lens wear. Though your haptics, though your fluid reservoir thickness, though all other factors are controlled, again, your ocular condition plays a very major role in the midday fogging. And uh, again, in the other hand, when I discussed about fitting a keratoconus without any allergic reaction, few members did not complain any midday fogging, and few members still complained, though the haptics are good, though the other factors are good, and still we encountered midday fogging.
Right. Yeah. And we'll take one last question here. I think one of the clinical tips you also mentioned is probably the most economic at that point in time is to ask patients to remove and put back the lenses after cleaning them and putting them back on to, enjoy their vision for that maybe 4 hours or 5 hours of wear time. Would you also recommend them to also clean, maybe directly not related to midday fogging, but do you recommend them to clean their lenses with the cotton bud to get rid of the front surface debris and also making sure that the lens is well cleaned before they apply the lenses? And is that something you practice and would you recommend?
Yeah. So the first point is you asked about the cleaning uh,
Yeah.
part, that how we can address or whether it is related to midday fogging. And in cleaning practices, I mean, when you're storing it, when you're reapplying it. So first thing is when we are dispensing a lens for about a value of around it's quite expensive when it comes to scleral lenses, and if you ask the patient to remove and apply it very frequently, then it's going to be troublesome. The patient is going to be really disappointed from the patient's point of view. So you try in those cases, if you are really able to find any of the factors that could attribute to midday fogging, you please try to check those boxes out, that your fitting makes good and your other factors are good, and still if the midday fogging is happening, then it is fine. But don't leave any factors or don't leave any known factor to cause midday fogging for that particular patient, because they're investing more, and for few patients it's a kind of a life changing moment when it comes to scleral lens fitting. So that's one of the points that I want to add when it comes to removing it, cleaning it, and inserting it back. So because when we try to reduce the frequency of removing it and inserting it, patient is going to be very happy, and they are again going to come back to us. So that's one of the key points in with respect to clinics. And when it's coming to front handling the front surface debris, and obviously yes, so it, and here I can see the question, won't it cause scratches? Yeah, we instruct the patient very carefully that use it very gently, use the cotton buds very gently to clean the front surface. Because when it comes to keratoconus who are having midday fogging, their texture, their debris is different from the patient who is having ocular surface disorders. The kind of debris that they are getting is entirely different, which when it comes to handling an very oily substance over the ocular surface, then just putting a drop of saline on top of scleral lenses is not going to help you. That time, you might ask the patient to clean the front surface with a cotton tip, probably. But you have to practice that. You have to give a training session to patients to make it happen in a very real, in a very safer way. That's the point that I wanted to have.
Yeah, yeah. So I think careful examination and demonstration will help us and make sure that the quality of lenses is still maintained. Because once there are scratches, again the visual quality will deteriorate. We also need to think about those optics factors as well, right? Wonderful, great. So I think with that we have taken most of the question which popped up on the chat. Couple of questions were answered while you were talking, so I've just taken the liberty of skip those because the session is recorded. So people can always watch back and get the answers, because there were some questions which related to something which you have already discussed as well during your presentation. So thank you so much again, Vignesh, for that comprehensive talk and enlightening us with the evidence available for midday fogging and assessment and management of how should we go about doing it.
Thank you, Fakhruddin, and thank you, Willis, for giving me this opportunity. Thank you once again,
Most
and
welcome.
thank you everyone for joining the weekend session.
Yeah, thank you so much. And we do have session planned over the next year. So this is our final session for the year 2024. Thank you so much for participating. And I hope that you have learned during our sessions and hope to continue joining us in the future. Those celebrating Christmas, I would take this opportunity to wish you a Merry Christmas and in advance, Happy New Year to all of you. Take care, be safe, and we will stay connected with the details of our future sessions. So thank you, Vignesh, once again, and thank you everyone for joining. Take care and bye
Thank you.
bye.